Hey guys, this is Lisa Shiver again. We're looking at transplants and organ donation in this presentation. First, we're going to take a look at transplants. You need to understand that there are different types of transplants. You've got the avascular transplants, which include skin, cornea, bone, heart, valves. With the avascular, I think of those as being the non-juicy tissues, if you will. So these are the ones that maybe don't have as much blood flow to them. Where the organ transplants, I consider those to be the juicier transplants. So that's your kidney, heart, lung, liver, bone marrow, and there are others on the organ list as well. With the sources of transplant, you need to understand the difference between an autograft, an isograft, an allograft, and a xenograft. Autograft is where you transplant or you receive your own tissue back. If you have a burn patient, they very well may take skin from one area and transplant it to the burn area. Or if you know ahead of time that you're going for a surgical procedure where you could donate your own blood early and then receive that back, that's considered an autograft. An isograft is where you receive a transplant from an identical twin, and it does have to be identical. There should be little or no rejection issues with an isograft or an allograft transplant. With an allograft, this is somebody else's part or blood or tissue, so you're getting something from another human. With a xenograft, that is an animal to human transplant, and usually that is heart valves is where that comes into play. When you have a transplant patient, your body's immune system is programmed to look for things that does not belong in the body. So when your body notices something it does not recognize, such as the new kidney you got, then it's going to initiate that response. You're going to have your white blood cells come into play. You're going to have your T cells, which are the ones, the lymphocytes that look for things it does not recognize as being its own. Your T cells are going to initiate an attack on whatever that new part is. So the tricky part with transplants is you're going to have to, or the medical team's going to have to make sure that we suppress that patient's immune system. So essentially we turn off that immune response so the patient's immune system doesn't attack the new part. Does that cause problems? Yes, it sets them up for infection, so they're immunocompromised. So we've got to think about things like that when you're taking care of a transplant patient. You know, something that may not make a healthy person sick could make somebody who's immunocompromised very sick. When we're working with transplant patients, you're going to see they will be on several different drugs in their drug regimen, and a lot of times these are started even before they get their new part. One of the type of drugs is called a T-cell suppressor, and I've got some examples listed there. You may have heard of Prograf or Sandamune. Notice some of them have immune in the name of them. But T-cell suppressors, they do exactly what you think they would do. They prevent the T-cell attack on new tissue. So essentially we're turning off the T-cell and only the T-cell. Some of the other drugs we're going to look at affect the whole immune system. So these in particular just stop that T-cell attack. There are some side effects that can occur, so we've got to watch out for the kidneys or nephrotoxicity. With the diet, you don't want these patients on grapefruit juice. And if you think about it, have you ever seen grapefruit juice in the hospital, or have you ever heard of a medication that we said, hey, take this medicine with grapefruit juice? So a lot of medicines are not compatible with grapefruit juice. Just keep that in mind. Please note that the T-cell suppressors are given with steroids and other immunosuppressants. So these patients are going to be on a combination therapy. It's not just going to be one drug, most likely. The steroids, if you remember back to studying that previously, steroids decrease inflammation. Steroids suppress the immune response. So steroids honestly are getting rid of redness, the swelling, the edema, those cardinal symptoms that you see with inflammation. They kind of make all that go away. It doesn't make the infection go away, but it does suppress the signs of inflammation. So just keep in mind, you're going to see this therapy in combination with steroids and possibly other immunosuppressants. Our second group of immunosuppressants are the cytotoxic agents. Keep in mind, toxic. Toxic does not sound good. We've got several examples there. Methotrexate or Rumitrex is in this bunch, and that's a common drug that we use for patients with rheumatoid arthritis. So with rheumatoid arthritis, we have patients whose T cells cannot differentiate between what is good and bad, and then you see the chronic inflammation with the joints, in particular with that disorder. So with the cytotoxic agents, we see a decrease in all cells of the immune system. So not just the T cells, it's going to be all cells. Side effect, you got to worry about bone marrow suppression. Are we turning off all the bone marrow, all the white blood cell response? And you also have to watch the kidneys and the liver with the cytotoxic agents. So these are a little bit more potent, if you will. They affect more parts of the immune system. But again, they will be given with steroids. Just in my personal experience, I've seen a lot of patients on cytotoxin and also CellCept post organ transplant. So all of these are used quite frequently. The third group of immunosuppressive agents are the monoclonal antibodies, and I think these are pretty neat. What we have done is given a mouse viruses and things like that, and let the mouse's immune system make antibodies. So we take those antibodies that a mouse makes and then give them to a human. And you might be thinking, why the heck would we do that? Well, we're providing passive immunity essentially. So to keep the human's immune system from being activated, we're just giving this patient passive immunity, or just directly giving them antibodies as a present, so their immune system is never triggered. Remicade is on this list, orthoclone, Sinulet, and Zenipax. I've heard a lot of Remicade use. These are given IV. The MD will need to be present, and we treat this kind of like a blood transfusion, if you will. So we monitor the patient for a couple hours after the infusion has completed as well. There can be some reaction, more like an anaphylactic type reaction is the biggest side effect, but we don't see the issues with the kidney and the liver that we do with the other drugs. And patients may go once a month for their Remicade infusion. It might be every other month for their Remicade infusion, so it can be done on an outpatient basis. The last drug I want you to be very familiar with is called Plaquenil. And if you were to look in your Nursing Central or your drug book and see what Plaquenil is all about, it's going to tell you it is an anti-malarial agent. Well, here's a warning. Chances are, unless your patient has traveled outside of the U.S., that you're not treating malaria. So don't tell your instructor or whoever you're working with that day if you're giving Plaquenil that you're giving it for malaria, because I bet that's not the case. We use this drug also as an immunosuppressant, and commonly is used for patients who have systemic lupus, rheumatoid arthritis, and you might even see it used in combination for those transplant patients as well. So keep Plaquenil in mind, but probably if you are giving it on a regular basis, you're giving it to suppress your patient's immune system. So when you're thinking about all these immunosuppressant agents, or you're shutting down your patient's immune system, or turning it off, if you will, you need to think about things like their diet. Will they have limitations with their diet? Can they have fresh fruits and vegetables? And the answer is they can, if the fruit is concealed, such as an orange or a banana. There's a protective layering on that fruit. That probably would be okay. They can have vegetables as long as they're cooked. We do need to limit, or actually restrict, them having fresh flowers in their room, because that stagnant water that would be in that vase can cause issues for the patient as well. So there are some things we need to consider as far as nutrition and their environment. We also would not want to totally restrict all visitors, but you would want to limit the number of people coming and going in your patient's room. And also, if the patient's white count is low enough, if their white count is 2,000, 1,000, then we would need to put them in protective isolation, and everyone that walks in that room would need to wear a mask. If the patient needs to leave their room, then they would be the ones wearing the mask out in the hallway. Alright, there are a couple different things to consider when talking about transplant rejection. 4 different types. You've got hyperacute, that occurs 1 to 3 days post-transplant. There's acute rejection that occurs 4 days to 3 months post-rejection. You've got chronic, which could occur 4 months to years. And then there's a graft versus host rejection. This is due to there being no close match. Maybe the patient received a new heart because they were about to die, but we knew that it wasn't a perfect match. It wasn't the best suited heart for that patient, but they had to have a heart. Graft versus host disease, we do see that every now and then. The patient may survive anywhere from 7 to 100 days. We are buying time, essentially, when we give a patient a part that wasn't 100% the best match, but we're just trying to extend their life. During any of these rejection periods, you, the nurse, need to monitor for things such as swelling over that site, sudden weight gain. Maybe they now are having hypertension, chills, fever. Chills and fever are going to be very significant, because keep in mind, your patients are going to be on immunosuppressive agents. That means we've already turned off their immune system. So even if they had the slightest little bump in temperature, I'm talking about 99.5, would be considered significant because of all the immunosuppressants the patients are on. They might have malaise, might see an elevation in their white count, you might even see an elevation in their SED rate. So as a nurse, it's our responsibility to watch for that part to fail, but also watch for signs of a systemic type issue. Nursing interventions. What are we going to do? The most important thing we can do for the patients is wash our hands. Again, just to reiterate on a previous presentation, the #1 leading cause of hospital deaths is due to healthcare associated infections. Watch for signs and symptoms of infection. Again, a low-grade temperature is significant with a patient who is immunosuppressed. Monitor that white blood cell count. If indicated, we'll have to put them on isolation. Different facilities have different policies as to when you put them on isolation. I've been to one where they said if the total white count was less than 1,000, you put them on protective isolation. I've also seen where a facility said 2,000. So find out what that facility requires as far as initiating isolation. And it's the nurse's responsibility to initiate isolation. Don't wait on a doctor or somebody else to come around and say, hey, this patient needs to know. It's on the nurse. We need to make sure these patients are avoiding all ill contacts. They need to avoid crowds, things like that. Make sure their nutrition is in balance, but yet they're not eating raw fruits and vegetables, or those fruits that do not have that protective coating on them. Good mouth care is going to be essential, because the easiest route for germs, bacteria, things like that to get into our body is through our mouth. And then just imagine the anxiety that's going to be involved, not only for the person receiving an organ, but the donor, or the donor's family. There's a lot of emotion involved here, so you've got to think about the big picture and what the patient's going to be going through. Alright, let's look at organ donation just a little bit. Got some facts here that I do not expect you to memorize or learn, but it's just more for a FYI. Somebody is added to the waiting list every 18 minutes. That is actually true. 9 people die each day waiting for transplant. That is true as well. It's estimated that there are 5,000 donors nationwide yearly. Another true statement. Surveys indicate that 8 out of 10 support organ donations. So when they did surveys asking folks, hey, would you donate your organs? 8 out of 10 folks said, yeah, sure. But then the reality is 1 out of 3 of those that are eligible to donate actually do when it comes down to doing it. Signing your driver's license is not enough. So that statement is false. That just indicates what your wishes are, but when it comes down to it, or when you pass away, you have to have a next of kin determine what happens to your organs. So hopefully you've communicated that with them, but the only way for donation to truly occur is if your family understands what your wishes are as well. So just signing your license or having that indicated on your license, that's a start. But when it comes down to it, somebody's going to have to sign the paperwork to permit that to happen after you have already passed away. So make sure your family knows what your wishes are. Not everyone can be an eye donor. That is not true. There's no age limit on eyes, and you'd be amazed how many people do meet the criteria to be an eye donor. The donor and donor's family pay for costs. That actually is false. The donor nor the donor's family pay for any of the expenses related to organ donation. And another false statement is organ donation occurs before all efforts to save a life are exhausted. That is false. We do everything humanly possible to save somebody's life before we consider organ donation. So just some interesting things to think about. As of recent, the Alabama Organ Bank has an online website now where you can go, and you can encourage your patients to go and go ahead and sign up to be a donor if that's something you're interested in. So it'll already be in their registry, it'll already be on file, so when that time comes, they'll already know what your wishes are. So that's actually something that's relatively new, but you can go online and go ahead and commit to what you want your done with your body once you die. Donor requirements: we have to have consent, obviously, for someone to be a donor, and that can be gotten in person by the next of kin. So next of kin is going to be parent of, spouse of, or child of. We also can get that consent by phone. The tricky part here is you need to have 2 nurses witness that next of kin, saying who they are, their relationship, and what they're consenting to. So, and of course both nurses would document what they heard. So ideally it would be done in person, but sometimes that's not always possible. We can get consent by phone if 2 nurses witness that. The patient must meet criteria for brain death, of course, and they must be free of systemic disease, malignancy, and infection. Not every patient is going to be a candidate for organ donation. So what we do in the hospital when a patient expires is that we are required by law, that this is the nurse, required by law, you must notify the Alabama Organ Center and also the Alabama Eye Bank to let them know about your patients. So when you call, you're going to have all your patients' information there. They're going to want to know about age and medical history and medications and things like that. And then they will determine, is the patient a candidate for donation? And if they are, a lot of times the organ center will get on the phone and talk to the family that may be there, or they'll get in touch with the family and talk through that process. If a patient or family, though, decide that they don't want to be an organ donor, that is totally fine, because we have to respect everybody's values and beliefs, but we are required by law to at least ask. And if the patient says, or not the patient, but the family or the next of kin say no, then it's a no. But if they're unsure, well, that might be an opportunity to give them some more information so they can make that informed decision. This little table just shows the need based. It has the organ needed, how many patients in the U.S. are waiting on this part, and then the patients in Alabama. So just to give you an idea of how many folks are waiting on parts, not only nationally but in the state. I do not expect you to memorize this table or learn this table. It's just something to look at. And that's all I have for organ donation and transplants.